The tragedy of later life is that they go from loss to loss to loss, and therefore they go from sadness to sadness to sadness.
When you begin to ask questions in the clinical setting about their sexual life, frequently people who have what appears to be a perfectly adequate and normal sexual life begin to tell it to you almost as an apology.
Point also that
Right.
Women experience the same kinds of losses, but they don't translate it into aggression towards self the way white males do.
Welcome to another edition of Psychiatric Recorder, a continuing education service from SmithKline French Laboratories. In this program, we examine some of the psychiatric needs of the elderly American. A distinguished panel of experts discuss such topics as sexuality in later life, depression, and paranoid projection, as well as residential care for the fastest-growing segment of America's population.
We as psychiatrists usually encounter two major syndromes in the elderly. And I would like to iterate the fact that it does not matter whether the individual is organically impaired, while it does to some extent matter, or whether there is no organic impairment of the brain. The individual presents himself with certain symptoms and with behavioral patterns that, if we understand them, will be sufficient often to help the individual, because understanding means support in a certain sense.
Moderator of today's discussion is Dr. Jack Weinberg, past president of the American Psychiatric Association and director of the Illinois State Psychiatric Institute. A member of the Committee on Aging for the Group for the Advancement of Psychiatry and of the Special Committee for Mental Health and Illness of the Elderly of NIMH. Dr. Weinberg has devoted much of his professional life to the study of the elderly. A noted author and clinician, he is also professor of psychiatry at both Abraham Lincoln School of Medicine and Rush Medical College.
The two major components that one sees in later life, one, and the primary one, is that of depression in later life. And I would like to explore that with you in terms of what is the meaning of it, of this depression, how often is it seen demographically, epidemiologically, and to what do you attribute its prevalence in our society. The second syndrome complex that one sees in later life is that of projection, paranoid ideas that come up in later life among the elderly. That too I would like to explore and to see what is it that brings forth this type of psychological response to the aging process.
Let's talk about sadness for a moment. What is it that distinguishes sadness from what we would call depression? It would appear, as we view what late life is like, probably, whatever else it is a time of loss. Loss in the sense of change.
Joining Dr. Weinberg is Dr. George J. Maddox, Director and Senior Fellow at the Center for the Study of Aging and Human Development at Duke University. Dr. Maddox, also Professor of Sociology at Duke and a member of the National Advisory Council on Aging at NIH, has conducted research into the social aspects of aging and human development.
I'm aware when we are looking over scrapbooks and pictures of myself 20 years ago, my children always laugh, and I'm not sure whether I want to laugh with them or not. I'm aware of a loss of an image of myself. Friends die. Even closer persons do. And there is an affect called sadness. When does that become depression from your point of view? I can see why there would be a lot of sadness in late life, but it's not clear to me at what point we ought to be talking about depression. That's critical in answering the question about the epidemiology of it. We've got to define the case.
Well, I thought Jack sort of defined it when he said that he is going to talk about patience. When he talks about patience, then although the affect of sadness is part of depression, the diagnosis of a depression in an older person, a patient then, is something that implies not only the affect, but certain other signs and symptoms, but most important, an interruption of function that requires treatment to ameliorate. The sadness that you're talking about, the sadness of loss of what was previously, is indeed a change.
Completing our panel is Dr. Robert J. Nathan, Professor of Psychiatry and Director of the Division of Liaison Psychiatry and Psychosomatic Medicine at Hahnemann Medical College and Hospital in Philadelphia. Dr. Nathan's clinical interest in geriatric psychiatry has led to research into the brain structure and socio-behavioral variables of the aging process.
I'm not so sure that all changes bring about sadness. I think that if you looked in your scrapbook, for example, when you were 20 and looked back to when you were 5 or 10, you might not feel sadness at that change. And I think the cultural determinants of looking when you're 50 to back when you're 20 and feeling a sense of sadness may be something there. But when the sense of sadness becomes all-pervading, when the sense of sadness reaches the point that it interferes with sleeping and eating and motility, as we do see in many of our patients, then these patients come to see us, and then we have to tease out a very difficult thing. What of these things are changes or losses that may have precipitated this depression? Frequently very real losses, loss of a loved one, and we know that for any age group, the loss of a spouse, for example, is considered a critical life event, and one that most people respond to very strongly and is a predictor in, for example, Holmes and Ray's method of viewing life event schedules, predictor of future illness, not necessarily only psychiatric illness. But then there are other losses that might be peculiar, and I don't know, I think we could explore this, might be peculiar to old age.
When epidemiologists have tried to deal with this issue, a lot hinges on the definition of the case.
Yes.
When the negative affect is being discussed, negative affect is not uncommon. And one can find in sample surveys 25-30% persons who in the previous week acknowledged significant negative affect. But that's very different from the treated cases where one has become a patient and where the more than the sadness is involved. And the estimates one sees are quite variable, but tend to be in the population generally in the range of 3 or 4%. And then estimates that for the older population it is much higher, but it's an estimate for a very interesting reason. The comments that an epidemiologist hears is that there is a high probability that psychiatrists, seeing an older person, is inclined to treat what appears to be depression as just a, quote, and I quote, a normal response. Is that a probability? Epidemiologists believe that, I think, that there is a probability that the physician, the psychiatrist, tends to underestimate significant depression in his own practice.
One of the aspects of growing old is the gradual loss, as Bob Nathan has indicated, of meaningful others. And meaningful others may not just be a spouse, and meaningful others may not just be even a loved object, but it could be someone with whom one has quarreled all of one's life and given a reason to exist. And if that person disappears, then something in the balance of that person has been upset. It is indeed true that not only are there some deficits that take place organically and physiologically for which one can mourn to some extent, but every loss means a separation from some object that was a supportive figure in some way in the matrix of that individual's life structure and lifestyle. The tragedy of later life is that there is a gradual isolation and aloneness that takes place in the individual. And I like to make a differentiation between isolation and aloneness. Aloneness is an intensely experienced inner affect. One can be in a huge stadium at Duke University and watch a football game and feel quite alone. You can eat in a restaurant where there are loads of people sitting around you, but if you are by yourself, you may feel alone. It is because you're separated from meaningful others. George, you've heard me many a time relate my own experience with my mother, whom I mentioned at the drop of a hat. So I keep her memory alive. I used to call her every morning when I came to the office. And you're entitled, Bob, to any interpretation you might give on that. And
I'd like to hear it.
I'll admit to it. And every morning she'd tell me the same thing and finish the conversation just before we hung up. I'm always alone. Now, Mother was never alone because she was in the home of my brother. She was ill, and we never left her alone. Then what did she mean when she said to me, I'm always alone? It would not do for me to say, Mother, you're not alone, because I wouldn't tell her anything new. She knew that she was not. But she was giving me a message. And in it, of course, as a psychiatrist is wont to do, interprets it. What she meant, I believe, was that that part of her which interfaced with me felt lonely for me before I even hung up. And that there was no one in our configuration that could replace that type of a relationship. And implicit, there was a rebuke. Why in the hell aren't you here? So that I never became angry about that. And provided with my silence the understanding that we mutually shared, that we both felt sad, alone, being apart from one another, and that it is fate or life or what have you that brings it about. There was a note of sadness in her voice when she said that. The tragedy of later life is that they go from loss to loss to loss. And therefore they go from sadness to sadness to sadness. And what you imply, George, is very much correct. That grief which accompanies a loss is something that needs to be worked through. Depression, which Bob has described, needs to be treated. And true, Bob, many a patient is brought to us or comes in because the family says he's depressed, is really going through a process of mourning for some object or a meaningful other. And it is
How common is that in your experience? It would seem to me to be an important distinction to make, because presumably a person who is grieving can very frequently be helped by more natural processes than being introduced into the medical system.
I can't give you incidence figures, George, but certainly one must clinically differentiate these two. My experience, for example, is that, and this is not just in the older population, but in all psychiatric populations, I am terribly unimpressed with the use, for example, of antidepressant medication in people who are grieving. In people who are depressed, it is a wonderful, effective tool for a psychiatrist to use. But if you get someone who lost a loved one and who is having a prolonged grieving process, you might be able to help them talk through if they don't have any source to do this. But the use of the medical tools, shock treatment or drugs, is in my experience ineffective. Now, I don't know how it is with you, and yet we see this constantly. We see 2 weeks after someone has lost something, the family physician puts them on an antidepressant because they haven't snapped out of it yet.
Well, in my experience, I do and have seen individuals who came in because of supposed depression, but who really were going through a prolonged grieving reaction. I believe it is by far more common than is described. The tendency often is to immediately enter into the medical mold and to provide something that would be of help. And let me give you an experience, a case, that it is not solely the issue of the loss of a meaningful other necessarily, but some sort of an abstract idea and a notion. I saw a woman in her 70s who had a previous depression when going through her involutional period during the menopause. And she had seen a psychoanalyst and was helped greatly, and she had some psychological know-how. And when in the age of 70-something she suddenly became depressed, she went to see her former analyst, and he said, "Well, you're in the 70s, go and see Weinberg." So she came to see me, and in the process of taking a history, she told me that it has been going on for about 2 months. And I said, what's happened? And she was unable quite to describe. But then, as she went on in my eliciting a history, she indicated that her husband, who has been an invalid and a vegetable, really in a nursing home for 5 years, and for 5 years she went there every day without fail, sat near him, even though he was not conscious at all of her presence, but she was sufficiently psychologically attuned to stay with him and provide some physical contact. She would hold his hand and thereby felt that she was participating with him and providing some sort of support. Well, her friends were disturbed that for 5 years she did that, and they urged her to take a vacation. There was no knowledge of how long this man was going to go on. She decided to take a cruise. And then she told the nursing home where this man was that she was leaving for 2 months, whereupon they said to her, "Well, Mrs. So-and-so, you never told us what to do with husband should he die." They had no children. And so it suddenly confronted her, and she stated, "Well, give him to a medical school for research." Then she thought, "I've never done anything about myself. What if I die?" And so she made a codicil to her will that when she dies, her body would be given to... And as she was saying that, she broke down and cried. Because she said, from that point on, I look at my body and I think it isn't mine anymore. I've given it away. And what's going to be done with it? So she was not only saying goodbye to her husband, but saying goodbye in a sense to herself, and she was grieving for those two losses.
You make it. You said this person had psychological resources, and
Yes.
That's certainly believable what you say. I would have expected an equally probable outcome for such a person is to be terribly angry by being put into that situation. Does that happen? It seems to me the more common, and I've seen this more in middle-aged people where there's the death of a spouse, where chronic illness has been involved, where I've observed intense anger, then followed by the perception that I have killed. My anger has killed this person, and a great sense of guilt. If you had told me that story about this woman, I would have found it equally believable.
Yes, well, one of the differences in terms of making a diagnostic evaluation between grief and depression is the amount of ambivalence that the individual has had in relationship to the lost object. When there is ambivalence, when there is as well hostility and anger, as well as affection, then there's much more likely to be a depression. When there is less ambivalence, then there's more likely to be a more clear-cut grieving process. And I think psychiatrists need to make the differentiation, and that requires a good history and an openness on the part of the individual to express what the real feelings have been, because then there is guilt. Ambivalence implies I was hostile, why didn't that man go? So I would be free.
This ambivalence and anger that you correctly point out, in my mind, once again, is what distinguishes the grieving process from the depression, and what I think accounts for an awful lot of the suicides that we see in this. 10% of the population provides about 25% of the suicides in this country.
And particularly that is true of white males in our society. Right. It gradually goes up.
That's correct.
All the way up.
Making a cultural point also that women experience the same kinds of losses, but they don't translate it into aggression towards self the way white males do.
Because they also have difficulty in accepting themselves in a dependent position. They can't accept dependency. Mm-hmm. Mm-hmm. Whereas women can, culturally determined. I would like to take a look at the other important symptom complex that we see in later life, and that is the usual and seeming paranoid projection that the elderly come in with or are brought in. I am reminded of a case where two women came to see me because their mother accused them of stealing her food from the refrigerator. They were taking it away, or taking the laundry out and bringing it back when it was all seemingly tattered or fixed, not to her liking, that they took her medication and took that away from her. And the two sisters were very upset because the reverse was actually true. They were the ones who brought the food into the home. They, the ones, did the laundry for Mother, and because Mother did not remember how to take her medication, she either took too much or too little of it, that they doled it out to her, but she felt that they were stealing it. The interesting thing was that indeed the mother, who was not sophisticated, accused them of stealing, and I said to them, let's understand what it is that your mother is saying. You told me just a while ago that when you came and told your mother, you can't handle money anymore. We are going to buy the food for you. You cannot handle laundry anymore. We're going to do it for you. You don't know how to take your medication. We're going to do it for you. What they were doing is to take function away from her. This is the role that she played all her life. That is, provide the food, take care of the household, and so on and on. And they were taking that away without providing another role for her. She was not sophisticated enough to say, you are infantilizing me. But she could say you're stealing. What she was actually saying in a symbolic sort of a sense, because patients speak to us in symbolic language, in poetry as I like to say it, what she was saying is that you're taking function away from me. And since she could not face up to the fact that she was dysfunctional, she projected, you doing it too.
A colleague just, I heard recently, gave two illustrations that are very similar to this, and making clear what a fine line there is between, we sometimes jokingly say that a paranoid person is what every thinking person is in a threatening world. The two illustrations from clinical experience was a confrontation between a mother and daughter over ordinary kinds of things, where they parted in anger, whereupon the daughter, wanting to make up to Mother for this, brought her a cake. And the next thing anyone knew, the mother was perceiving the cake as poisoned, thinking her daughter wished her ill. The other is the older person who believes that someone is stealing their mail. They aren't getting as much mail sometimes as they used to, and they look for that contact with someone that's supposed to care about them, and it's not there, and they cannot believe, understandably, that people would not continue to write, so someone is stealing. Those two illustrations strike me as especially poignant because they are so everyday,
Right.
and have this outcome that is so unacceptable in a way, because after a person continues to talk so unrealistically about the environment, people tire of that. That's true certainly of non-professionals, but I suspect professionals must see that as unusual. The person continues to insist that the world is as everybody knows it isn't.
No, but these reactions, I think, are really ubiquitous. And the trap that we as psychiatrists fall into is that of giving them superficial explanations. Most psychiatrists, when dealing with something like this, would indeed see the projective mechanism involved and would indeed be able to explain it to himself and to the relative. What I don't think enough of us do is to go beyond the simple projective mechanism and see it as symbolic of the disruption of some sort of interpersonal contact. Because if you do that, then you're into a therapeutic situation, and you can indeed do this. One of my first geriatric patients, who I began seeing at 65, who is now 85, who for the last 20 years has had a grossly elaborated paranoid system. And for years and years, we spent a lot of time going over, do I believe that the FBI is tapping her phone, all sorts of things. And finally, I learned my lesson, that what I would do whenever this thing would reach the crescendo that would require calls in the middle of the night to me and things of this nature, I would begin to look for what is going on between you and your daughter. What is really upsetting you? But that's not much different, once again, than we do with our younger patients either, and I think that's the point.
In the therapeutic situation, you don't just deal with the elderly person if there's family around. You deal with the family. This is what one might say manipulation of the environment, not in a pejorative sense, but rather explain to the children, as I did to them, what it is that mother was doing. One has to deal with mothers. Projective techniques, but at least the daughters, if they understand it, do not get angry and begin to argue with her. So one has to do a double job. And like with children, absolutely, one has to deal with environmental issues. You see, we see that same type of mechanism in children. The little boy or little girl who runs into mother who's carrying a tray of glasses, and the glasses fall and break, and mother is angry at the child, and the child says, "You made me do it. You pushed me.
See what you made
See
me
what
do.
you made me
Yes.
do." So that there's a projection in one's inability really to assume responsibility or to indicate that I have been at fault or something is wrong with me. It's an immediate projection.
You know, and one of the implications of what you're saying is a point we've touched on many times before. In geriatrics, like in pediatrics, now I don't mean to bring up the imagery of being infantilized,
Right.
but the third party becomes critical here, both in terms of understanding what is going on and in terms of making some decisions about what can be done, if anything, that is helpful. The idea of geriatrics without involving the third person seems essentially an impossibility.
I think we could spend some time on that, because once again, it's always easy to make the cavalier statement that all kids of older people do, positive or negative. And actually, it's a highly complex sort of thing. This lady I was just referring to, her daughter, now herself in her 60s, can't understand and gets upset when she and her husband want to go away and want her mother to leave her apartment to come over and stay with their house and their 3 dogs, and the mother then, because of her particular psychological problem, develops all sorts of elaborate paranoid ideas about going over there, but in essence saying, really, look, I'm having trouble in my own little apartment. I don't want to go over to yours. And eventually the daughter calls me and says, "How will you please make sure that my mother goes over?" And I say, "No, I think at this time, if you want a house sitter," I repress or suppress, "you're old enough to hire one. But you're going to have to get someone to sit with your house." That goes on. But the people we get who come in and say, "We have to get rid of mother," or "we have to keep mother," all present different problems that we have to deal with.
We're dealing with the everyday variety that is not too difficult to understand, and maybe even not too difficult to begin managing. It would seem to me, though, there's a very different problem when one has, how should one say this, a significantly paranoid individual where there's not the capability of going on. What different kind of strategy is involved?
What we provide is a combination of psychotherapy, in this particular lady's case, when the paranoid thing reaches a point where she begins to call the police and call our 2 senators, and the situation gets tense, then we use some medication in small dosages. I have made it a point of principle with this lady that I do not want her hospitalized, and I will see her frequently, and I will see her daughter and her son-in-law. because I don't want her to be placed in a hospital. And at this point, after 20 years, the beautiful thing is that she will come now to the office and we will talk about this, and I will try to figure out what is going on and interpret it. And then I will also say, let's cool it a little bit. Neither of us want this to get out of hand. And she says, yes, I understand, but, and then she goes through it a little bit more. And then I say, okay, now, I think it's this, and let's see what happens, and call me in a couple of days and tell me if you feel more comfortable. And every once in a while she'll go off and say, but you don't really believe. And I say, at this point, I don't have to believe.
That's a good therapist. And the point is that should be emphasized in terms of the therapeutic regime of these individuals, to use some medication, to be sure, but then also frequent exposure to the individual and frequent visits of that individual. I used to make it a point that when I had 3 elderly people, and if my psychotherapeutic hour was 45 minutes, I would see these 3 people for 15 minutes each, but 3 times a week. So that I'd use 1 hour to see 3 people to establish the interpersonal relationship and the trust that they might build up, or at least the semblance of feeling that this man does understand me, even though he may not believe, but there is something that is going on that he provides. So that's an imperative, I think, in working with the elderly. Particularly is that true with some of the people who have some organic brain dysfunction, chronic brain syndrome, who don't remember. You have to be exposed to them as a therapist quite a number of times so that they'll remember you and make connections between the previous and these moments.
I think Jack is raising a point that those of us who have been trained as analysts have had to wrench ourselves away in dealing with some of the older patients from this concept of a 50-minute hour. That it, in particular with some of the organic brain disease people, it's probably better in my experience to see them for shorter periods of time, but on a very regular basis, than to try to do a 50-minute hour. What I try to do is keep myself flexible, that I can expand or contract.
Right.
And within an academic setting, I can do this. I don't know whether in private practice you can have quite that kind of luxury, but it's sometimes necessary.
It's interesting, George, that that some of the most significant contributions to geriatric psychiatry come from a group of psychoanalysts who had dared to go into this situation, but they've also felt that there's modification of the technique, a great modification, much more realistically oriented, and the prohibition of not touching a patient is not true as far as the elderly is concerned. You do reach out and hold their hand. You do pat them on the back. You provide a contact which is very realistic between yourself and the patient, which is very meaningful.
This is something that is demonstrated beautifully within the general hospital setting on a psychiatric consultation with a geriatric patient, where you send your resident to interview the patient, and the resident comes back and says, it's an organic brain syndrome, I can't find out anything about it. And then you take your medical students and the resident, you go to see the patient, and you put your hand on their hand, and suddenly all sorts of material comes out. And if you're feeling sadistic at the time, you say to your resident, I thought you said you couldn't get any material. And if you don't, you simply say, do you see anything that I did that you didn't do? And he says, no. I was nice to the patient. I talked to the... And did you put your hand on the patient's hand? No, I didn't do that.
Taboo. I'd like to raise another point, that often individuals are brought to the psychiatrist because they seemingly hold on to things. They begin to conserve and hoard things, food and all sorts of objects. Medications. The family can't understand what's going on. And the point is that, as I see it, and I'd like to verify it by you and you, I feel that as the individual loses more and more meaningful objects, persons, people, he begins to hold on to inanimate objects with which he or she has shared experiences.
You're describing me.
Right.
My study is filled with objects that stand for relationships.
Right. We hold on to an old theater ticket stub or to a
I hope you're going
program.
to say that that's good.
I love it.
Very good. Thank you. Thank you, Doctor.
And you spoke about, I'll send you a bill later. As far as you were talking about pictures, the elderly surround themselves with all sorts of photographs, because once they take a look at the object, in the absence of other meaningful object, then it is evocative of a pleasant experience or something that has happened. And they lost their friends, they lost their relatives, but there they are in the pictures, and every time they look at them, it's again flooded with feelings which are so terribly important. It makes them feel alive.
Both of you have had a lot of experience in teaching medical students. I have, in my own way, also over the years, had many contacts with medical students. And what we're talking about would seem to give at least some explanation of why we have such difficulty in teaching about late life. Let's assume that medicine attracts fairly independent, aggressive people. And to the extent that the selection process plays out its intended course, that's what you get. That kind of person would seem to have great difficulty, quite apart from the intellectual understanding of coming to terms with loss and dependency in late life, of doing more than acknowledging it intellectually, but in fact coming to terms with it, knowing how to respond to it, even wanting to be able to make the subtle distinctions in diagnosis. That's been my reading. You're much closer to the situation than I am. Is there a special problem in teaching the medical student to diagnose and to respond to this kind of thing?
Well, I have trouble there differentiating, as a psychiatrist, the problems that we have teaching medical students to look at the psychological aspects of life in general. And when I add to that the cultural phenomena that we had been discussing of the cultural biases toward the aged, then I have trouble differentiating this. If, we're reviewing an article just recently, Carl Menninger's classical article on polysurgery and polysurgical addiction, where he makes the flat-out statement that all physicians, psychiatrists included, are sadistic and voyeuristic, hopefully sublimated. And what that would do in the treatment of the aged, I haven't really explored in my own mind. But certainly we find that the conviction among medical students that, you're dealing here with a population that has no resources, and that they're at endpoints, and that, therefore, why get involved is common. But how much of that is because of the personality of the medical student or not, I'm not sure.
Mm-hmm.
Our discussion continues in just a minute. First, here's a message from SmithKline French Laboratories. The schizophrenic patient, often isolated from his family, is lost in a private world of hallucinations, delusions, and anxiety. For a wide range of such patients, Stelazine, SK&F Company's brand of trifluoroperazine hydrochloride, provides effective relief from these and other psychotic target symptoms. From withdrawn and apathetic to anxious and overactive, convenient BID Stelazine helps return the psychotic patient to reality. And since Stelazine usually does not cause excessive sedation, it works with your therapy, not against it. After 18 years of extensive laboratory research and clinical experience, no other antipsychotic agent has demonstrated significantly greater overall effectiveness and significantly fewer adverse effects. These facts make Stelazine a first choice for therapy. You should be aware that Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Also avoid using in patients hypersensitive to phenothiazines. As with all antipsychotic medications, physicians should be alert for neuromuscular reactions, including tardive dyskinesia and other adverse effects associated with antipsychotic therapy. Dosage requirements of patients on high-dose long-term therapy should be evaluated periodically. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions. Stelazine, a first choice for therapy, helps return the psychotic patient from his own private world. This program continues on the second side of this cassette. We now resume our discussion of aging in America.
I must say this, the way I find it convenient to teach psychological geriatric material to the students, which I do in the first year of medical school, is to make whatever I'm saying relevant to themselves. If I'm able to take the cultural value orientations I talk about and say, you are going through that process right now, and that therefore it's going to affect you when you get older in terms of viewing yourself.
That would seem to me to be very threatening. You don't
The
find
remarkable thing is that there is an enormous response to that, because they do believe that if they have the intellectual awareness of it, they're going to make some change in their method of life, not knowing that they probably will never be able to change. But nevertheless, it is something that is posed to them as a problem that possibly could alter their being. And then it becomes something relevant, and in terms also of their relationship to their parents, how they relate to them. And in many, many ways, as I discuss these issues, they begin to see themselves vis-a-vis their parents. And in some way, it touches them. And I've been successful in getting a number of people interested in aging, who then, I can point with pride, quite a few of my students who have gone into the field simply because they were touched very early in their experiences.
I want to remind you of an experience that illustrates this in another way. You may recall, 3 or 4 years ago, had a conference, a working conference for family medicine residents. And the conference was designed to deal with issues they had selected, what it was that bothered them. We asked them, how comfortable are you with the older people you're seeing, and what makes you uncomfortable? And they had specified 3, 4, 5 items. One is, can you have a viable practice with older people? It's the same question people used to ask about alcoholics. What if you admit to being interested in alcoholism? Does that change the nature of your practice? And then the second issue was the diagnosis of people with dementia. How do you deal with a person where you're not sure of their capacity to talk to you? And the third issue had to do with psychopharmacology. What do we know about that? And then the next issue is the one we asked you to speak on, which had to do with sexuality in late life. And my memory is that until you spoke, we had fairly academic discussion. People talked very coolly about how you manage older people in the practice, and how do you diagnose, and what do we know about psychopharmacology. But when you spoke, I had the feeling that the audience became involved in more than an intellectual way. And do you remember this?
Yes, indeed I do, because I do try to involve my audience emotionally.
And you did that day, I recall.
Experientially. And
they seemed uncomfortable. My reading was that I sensed discomfort in the room when you began to talk.
Right, because when I speak of sexuality in later life, and we need to talk about that, I mean, psychiatrists do have to deal with that, we have to remember that if one has been active sexually in earlier life, one is going to be active sexually in later life. And however, sexuality is denied to 2 poles of the life cycle, the young who shouldn't and the old who ought to know better. Well, the point is they do know better, and therefore they are involved. And however, it is not sanctioned by society because society feels that they shouldn't. It's the experience that you have related to us about presentation.
Medical students
you presented
about this
about a
issue.
medical student showing them a film of elderly people engaged in sexual activity, and they became terribly upset by it and so on, while they themselves might retire across the hall and engage in that sexuality. It is to a great extent the fact that we don't believe that our own parents have had sexual experiences. We have to deny that. We don't believe that they have had romantic lives and so on. We have to deny that. And so there's a transference to the older person. And it is as if he should not, he ought to know better. And it's passé, and so on and on. The fact,
Dr. Renshaw, that
Yes.
Loyola was looking for material that would depict the cultural recognition of sexuality in late life, and was absolutely unable to find any cultural recognition of sexuality. Now, it's not that easy to find in other cultures, but she does find some indications that other societies can, in fact, acknowledge this. But there is no acknowledgement.
Yeah, but and this, though, reflects back on the older person who, when you begin to ask questions in the clinical setting about their sexual life, frequently people who have what appears to be a perfectly adequate and normal sexual life begin to tell it to you almost as an apology. I know I must be terrible, but, my wife and I still enjoy making love to one another, et cetera, et cetera. And you say, well, why must you apologize? And they say, well, the kids, I think, would really wonder what's going on with us.
as an anecdote of that, the belief of the young about the elderly, I recently gave a talk about sexuality in later life, and a young man after the lecture came up to me and told me that he has a friend who is a radio ham and who established contact with an 82-year-old lighthouse keeper. And he would talk to him daily, and one day he talked to this elderly man, and the man said, "Say, I've got to stop this because my girlfriend is coming up." Whereupon the young man was so amazed. He says, "You still have a girlfriend?" He said, "Yes." He says, "Do you still have sexual relationship?" He said, "Yes." "I'll admit that it takes a little bit longer, but it's time well worth spending." And so,
the response to this kind of story to the medical students with whom I'm most familiar, well, perhaps make them smile, but I have reason to believe they're still a little disbelieving. And their tendency, if I can generalize very broadly, is to believe that if someone tells you that sexual interest is at end when they're dealing with a 45, 50, 55, it is, what do you expect at your age? There is a widespread belief, a self-serving belief in some ways, a decidedly cultural belief, that sexuality ought to disappear. And when Masters and Johnson began to speak to this particular issue, I guess many people have tended to overlook what Masters and Johnson said about the capabilities of sexuality in late life. It's just so that culturally, we don't really want to believe that. Now, I found this among people who otherwise are oriented to research, who think of themselves as quite intellectually rational people, who nonetheless will accept a cultural prescription that late life and sexuality just don't belong together.
Well, as Jack has implied, at least implied as I read it, that the children need or fantasize this Oedipal victory, that their parents are no longer sexual, while they, of course, are. I'd be interested, I don't have a lot of experience in this area, but how since we have now many more grandparents around than we used to have, how do these younger people view their grandparents? Are they equally unaccepting of the sexuality of their grandparents as they most certainly are of their parents? Because my impression is that there's a softening of this between children and their grandparents.
Indeed,
whereas
there is. And then there's a historical shifting that George Maddox talks about in terms of alterations and changes. But I'd like to also indicate that I'm not speaking solely of genital sexual experiences, but the need of an individual to have tactile relationship with another human being. It starts in infancy. When the mother feeds the baby, she does three things at the same time. She feeds it, she holds it, and talks to it. The triad of all social interchange. It's the paradigm and the model. We never give it up. We never give it up. When we have a social occasion, people come to your house, you shake hands, embrace, push a glass of varying amber-colored fluid into their hands, and then you talk. And that's not given to the elderly. And one of the relationship between the grandparents and the grandchildren is that they don't spoil the grandchildren. They don't have the responsibility to raise them. And when they come into homes and say to the very young, "Johnny, give me a big hug and a kiss," Johnny will do so. He has not become prejudiced against the elderly. But if she walked into her home and saw her big son, who is 50, and say, "John, Big John, give me a hug and a kiss," he would take her to the shrink.
You know, there's another aspect of our culture that makes sexuality even more difficult. We associate privacy with sexuality to an unusual degree, so I've always thought of this society as one that depends very heavily on shades and closed doors. And when we recognize then that privacy and sexuality belong together, which has already been made complicated by our cultural assumptions that sexuality doesn't belong, then imagine the situation of a person living in a long-term care facility where there's no way to think about. This becomes then the Puritan environment where you give up all those kinds of things that you have assumed to be natural and normal. That's changing very rapidly. As one listens to the discussion of knowledgeable, well-trained administrators of such facilities, I think every one that I've heard described in recent years has some provision for privacy.
Right.
And they don't like, unless things are changing, they haven't liked to talk about this publicly because as they describe the provisions they make for allowing people to express their sexuality, but in private, according to their preference, then that sounds like provision for a certain kind of immorality. When you recognize that very frequently these people for whom the privacy is being provided are not married. Yesterday I heard a fascinating discussion, Jack, this will interest you, because this was on the Over Easy program that KQED is developing, and they had a lawyer from New York talking about the problems of living together in the modern world without being married. And it took a while to realize she was talking about the increasing commonness of living together without being married among people, speaking of cohort differences, and the way in which the younger people of the 60s ought to be able to understand this. The pressures to do that are primarily legal ones. You lose certain rights to Social Security if you are married. There are a lot of legal barriers to being married in the current environment, and so a larger and larger number of older people are living in what in my generation one would call living in sin, but it's being talked about in the coolest way now by people who are observing the modern scene.
I wish I could accept that indeed, because the administrators say that they are providing these opportunities, that this is what I see when I consult to a nursing home or an old age home. I'm afraid that it's a long road to hoe still, because not too long ago, and this I'm sure is universal, I was called in because this 73-year-old man and this 80-year-old lady had been found in his room in what the aide felt was an absolutely terrible position.
A compromised position.
Yeah, and that they were terribly upset about it and began to put, very strong pressure on me to do a psychiatric evaluation of the man and the woman. That is at least an improvement, because it just used to be the man that I had to do the psychiatric evaluation on, and I refused, because I said, I don't know what is going on, but what is the aberrant that you're worried about? And I said, fortunately, you don't have to worry about pregnancy. And they didn't like my humor. No, not at all.
It is difficult. The environment which we provided in hospitals, I mentioned the term Puritan in the negative sense. Remember Bob Kastenbaum some years ago pointed out that in long-term care facilities, that especially those that were housing people with Italian backgrounds, he said, notice the absence of wine in these places, and how humanizing, how socializing it would be to have it there. And you have to ask, why is it so antithetical to have those amenities? Why would one not have the possibility of continuing one's lifestyle, whether that is having a glass of wine or having a cocktail or having sex? But we recognize that culturally those don't fit. And so that increasingly as one gets old, one faces an environment where it's increasingly difficult to do the kinds of things that one has.
Well, I think it's important for the physician who sees the patient in his office, and not necessarily in a long-term care facility, but rather in his office, to get a good history, a sexual history, and the frustrations that the person feels. Because not infrequently, what will be brought to the psychiatrist's attention are different type of sexual expressions in the absence of frank sexual genital experience, so that masturbation appears more, and it scandalizes the children and others in the family, whereas it may be now sanctioned by society and sanctioned by the psychiatrist. Exposure will take place. One regresses to earlier modalities of sexual adaptation or expression to one's sexuality. And it is important for the physician to recognize that this may not necessarily be such a psychotic type of behavior. And those are things that people will come to the physician
The ultimate
with.
stereotype has been, and we say this with some amusement more often than not, but I'm sure it has serious connotations, the dirty old man, which in its extreme form is saying that a person who is older, a male who is older, that would express an interest in sexuality, and especially in an inappropriate context, that is perhaps the most unthinkable, unforgivable thing. Now, there is not a counterpart of the dirty old woman, is there? I'm not aware. This should emerge.
It should emerge,
But it's not with us now, I don't think.
Jack has written about this, I think, very eloquently and touchingly about, as he had said earlier today, the need for touching. And so often the dirty old man turns out to be a man who has this need to reassert his masculinity, as it were, by being touched or by touching, and that a nurse's hand on his shoulder is an amazingly reassuring thing, and then it gets somewhat out of hand when the nurses see a response and then get upset by the response. But one of the things that I have seen in training people to take these sexual histories is almost a recapitulation of psychoanalysis. They say, well, I asked the patient. And I say, what did you ask the patient? I say, do you worry about your sexual life? And the patient says, no, I don't worry about my sexual life. There it is. And yet they wouldn't do this with a younger patient. They would take very careful histories, and they would introduce it tactfully, and they would then go on to ask questions. And with the older patient, they say these things that confirms in my mind that they don't have a sexual life, and let's get on to something else. And it has to be done
Well,
the
even
same
more
way.
striking now is the necessity to talk about something which is partly the outcome of demographics. Our average expectation of life at birth is 72, but there's that 7-year spread between men and women, so that in the upper age ranges, we're talking about overwhelmingly women, 2 to 1 in the very upper age ranges. If interest in sexuality can be maintained, then it's more likely to be unisex. I'm seeing more and more references in the literature about perhaps an even more unacceptable way. Maybe as we are coming to terms with male-female, and that's hard enough for us. The notion that there would be sexual gratification of female-female or male-male would be even more difficult to tolerate. Have you encountered this in your experience? There are more and more references to homosexuality in late life.
Well, I think the question is, what is determined as homosexuality?
Yes, all right.
This very couple that was lying in bed, the 70-some-year-old and the some-year-old men, were they really having sexual relationship, or were they holding on to one another for life's sake? And this is interpreted by us. The minute we touch someone, it's a sexual advance. And we need to understand the need really for contextual relationship. And the fact remains, as you've indicated, in later years, there are 2 women for every male. And male have less problems, but women certainly will have problems. And one of my colleagues in Colorado suggested that in later life there ought to be polygamy. So another colleague said, group nagging, never.
Here's another cultural stereotype.
Another cultural stereotype, right. But there is that particular need.
I'd like to bring up something, Jack, that is bothering me and that continues to bother me, and I don't have the solution, but I'm sure you do. And that is, we both, at this point, see many cases in consultation, including many of our colleagues who bring in their parents, and we do our best in trying to not hospitalize, institutionalize, but it reaches a point frequently where we say, and the relatives are in agreement, that it's time to place the parent into some sort of an institutional setting. And that's when I go off the wall, because I find that I cannot make a decent referral. I spent last Tuesday going around looking throughout a close to a 25-mile radius from Philadelphia, since many of my patients live there, and they say that they would like the parent to be institutionalized in a place near their home. No, in Philadelphia, we have the Philadelphia Geriatric Center, but you can't send every patient there. And then the question is, well, how do we find adequate places when we go to visit them? I came back, quite frankly, I was sick. I couldn't talk to anybody for about 4 hours, and what's the solution to adequate facilities for those that need the protection of a nursing home or something of like that?
I don't propose an answer, but I do want to respond to what our own experience is in Durham, North Carolina, because there are at least 2 components of the issue you're talking about. One is how one makes the decision that removing the person from their more natural home setting is in fact advised. And then the next question is, having made that decision, where is the appropriate place? And that implies that there is a lot of expertise that needs to be brought to bear on that we have no right to expect a physician to have been trained to muster, much less to have. That's why I've always felt that of all of the kinds of patients who need to be put in a multidisciplinary context, it would be the older person. So many of the problems that are rather common in late life simply defy reduction into somebody's discipline. We have found it important to put together the medical and the psychiatric to see them as related and to have easy referral. At the same time, we put in that context people who are skilled in knowing how to mobilize community resources such as they are, get maximum use from them, and whose job it is to have the best sense of, given the options, whether they are thought of as not adequate options at all, but the best option that's available. Now, just the things I've described in the last few minutes go so far beyond what we would have a right to expect from any physician, a psychiatrist included. It would say that any psychiatrist trying to operate alone is terribly handicapped in dealing with that kind of problem, it would seem.
Well, to address that, I didn't do this on my own. I had my social worker and my nurse tell me the best that they could come up with, and I went out to see these various privately owned nursing homes, and to my mind they were inadequate. Well, what happened was I came back and I told my social worker this, and she said, I think you're operating in the clouds, so that we've set up another day that we're going to go out, and she's going to go with me this time and tell me what's realistic and what isn't. But
No, go ahead, please.
The
The problem is you. And I like you for it, because what you're indicating is your humanness in the situation, and your assessment, and maybe your own dream of what a nursing home ought to be like. Because the very word nursing home implies something very emotionally laden, two words, home. When we use the term home, it's evocative of all sorts of feelings about a place, my privacy that you talked about, my castle, be it ever so humble, it is my home. And it is evocative of all of that. It might be a terrible place, but it's still home. If you place an individual in a home, then that ought to, it is as if you're making a promise to that person. Couple that word home with nursing. The mother nurses the baby. It's a nurturing type of relationship. And so a nursing home ought to be a nurturing environment in which an individual feels at home. And it isn't that. And so when you walk in and you try to do something for the patient, this is not so, it's very disturbing. So it is evocative of this type of a situation. And it's terribly troublesome. And George hit it on the head when he stated, do we have not only the competence to do all of that, are we trained for all of that, but the emotional makeup?
Let's get some sense of the proportion of what we're talking about, too. There are over 22,000 of these places that you might have seen, and with well over 1 million beds at the cost annually of $10 billion. That's not a minor problem to be working on, and one begins to ask, who's working on that kind of problem, and what kind of solutions are there? When you said you went to a select number of nursing homes and you didn't like what you saw,
I felt I had been in a bathroom with deodorant most of the time.
Well, the 22,000 nursing homes are quite varied. Just as we said, let's not talk about the older person. It's very difficult to talk about the nursing home. There are clearly places that are better and worse. But one of the things I think that has captured our imagination a bit is that if we don't like what we see, whose responsibility is it to do something about it? Now, let me give you a somewhat idealistic kind of response. Our geriatric evaluation and treatment clinic works very closely with our family medicine training program. And we were concerned to develop teaching sites. And we built on a very common sense observation, namely that the family medicine practitioner who has a geriatric clientele is going to follow some of those people inevitably into long-term care settings. If they don't like what they see, what can they do to make those long-term care settings more attractive places? So we asked them to specify what it was they didn't like about them. If it's the smell, the absence of interaction. They usually complain first, however, about wasting time. They went in that situation and they didn't find the personnel adequately informed, so that they had to do things they didn't ordinarily do. The question was, what can they do about that? Well, one of the things this family medicine practice did was to begin holding training sessions. They redefined this as a training site. They tried to make it a better place. What they found is that the staff was very appreciative of this, and the staff began behaving more like the physicians wanted, and this has made an impact. These people have no fantasies about changing life in the other 21,999 places, but they lit that candle where they were. They now have at least one place where they are much more relaxed about sending a person on the assumption they will get the best care available. They made a difference in this particular case.
Absolutely. And for example, one of the things that our geriatric section of the Community Mental Health Center did when it got established was to make immediate contact with all of the nursing homes in the area and offer our services and continue to offer them until we indeed were able to get some training programs going. But these are a very limited number. I don't know whether it's like this in Chicago, Jack, but I get called to see patients in the general hospital. Please evaluate. And the evaluation comes out that this is a patient with a severe organic brain syndrome, a psychiatric diagnosis. Okay. Before I write anything on the chart, I call the attending physician and I say to him, if I write this down, what are your plans for this patient? And he says, well, the family says that this patient should go to a nursing home. I say, if I as a psychiatrist put anything on that chart, you're not going to be able to get the patient in any nursing home because they will not accept a patient who has anything approaching a psychiatric diagnosis. So we're playing some sort of a game, because I, on the other hand, say that if they send this patient to a nursing home that is so prejudicial against patients with, say, senile dementia, am I doing the patient any favor? And yet, when I specifically, as I did last week, called nursing homes and said, I'm a psychiatrist at Hahnemann Hospital. I am interested in sending patients who need either short-term or longer-term care to your facility, older patients. I would like to come out and visit the facility. Half the people said, I'm sorry, we don't take that kind of patient. And that was it.
I would want to emphasize the point of the importance of having a facility in a community, if one can, where there's the possibility of a comprehensive evaluation of the situation of older people, what their strengths and problems are. Because as families bring an older individual there to ask questions about, can this person be maintained, we find that in general families want to maintain this. We find very little of the desire simply to unload parents. What they do need is help with this evaluation, and second, should it be necessary, after a good psychiatric and medical and social evaluation of these individuals, to help them find the most adequate place. Now, I would only make one other point. We have felt an obligation to make a difference in these long-term care facilities. It's not enough to complain about them.
I agree with what you've said, George. In addition, I think we need some more research in this area. I think we need research in the area of what distinguishes the populations who are living independently from those who are in nursing home. It very well may be the factors you mentioned. I think there may be other factors as well. I think there may be more purely psychological factors that have to do with loss, precipitating a great deal of the things that we see that eventually get into the institutionalized setting. I don't think we can stand around wringing our hands anymore and saying, gee, there's just nothing we can do about it. I think we're going to have to get involved, and that this is a legitimate obligation of those of us in psychiatry to begin to get involved, doing something within these settings. Now, there are some institutions that indeed begin their own nursing homes. I don't think this is ultimately going to solve it. It may, but I think I have found that most of the people who are running nursing homes, not all of them, but most of them, are interested in improving their level of care, and that they are interested but not always able to afford consultation and instruction, and yet it's to the mutual benefit of these institutions and we as psychiatrists to improve their level of care so that indeed we do have an adequate place to have patients go who are in need of this kind of treatment.
What we were trying to indicate is the type of practice that the psychiatrist has in his office and the type of problems that he is faced with when an elderly person either comes himself or is brought by others, both for evaluation and for therapy. We have indicated that there are issues that need to be diagnosed, such as depression, which is one of the common phases in the later life, one of the common symptoms, and that there is a need to differentiate between depression and grief. Grief needs to be worked through. Depression needs to be treated. Depression is by far more severe. The underlying basis for depression in terms of loss of meaningful others is one of ambivalence, and the more ambivalence there is, the more likelihood is there that it's going to be a depression, recognizing all the time that the elderly person goes from loss to loss to loss, and therefore he's sad and presents a picture of sadness and one of grief, and one can attempt to work that out on an ambulatory basis. We have tried to take a look at the usual symptoms of projection. As the elderly person goes further into his life, he loses more and more mastery over his own impulses and over his own functioning. He loses control over them. And it's a very painful and anxiety-producing situation to face one's own disintegration. And not infrequently, this is projected outwardly. And it is as if an attempt is being made at restitution of maintaining the integrity of the personality. And so one throws it out, and it is as if others are doing it than oneself. We have tried to take a look at such issues as the conservatism of the elderly, not only their rigidities, but also their need to conserve things and to hold on to things, and to the more cells they lose in their brain, the more relatives they lose, the more will they hold on to objects with which they have shared experiences. It is as if that is going to continue to give them some sort of continued life, and so on. And we have also indicated how one needs to approach a sick individual, an emotionally disturbed person who is seeking support, who is seeking some sort of contextual relationship. And if the individual has some chronic brain syndrome, the need for more repeated and constant contact with the helping figure. And therefore, the treating psychiatrist might reduce his time in seeing the patient, but see him more frequently and provide a type of support, and to make himself available to that individual by telephone contact, and thereby provide some relief. Furthermore, we talked about sexuality and its meaning, and also the need for careful history taking. And while I'm on that, I would like to state that it is imperative, as Butler has indicated, to do a life review. That's what a psychiatrist does with a patient. He goes through the life experiences and allows the patient the triumphs that he has had, and sometimes allows the patient to have a triumph over the therapist, as Goldfarb would indicate. And above all, to remember that each human being is an individual unto himself. Each elderly person has a story to tell. He's a novel for us to read. And when we do that, then the patient is aware that we are interested, and that in itself is supportive and helpful. Also, we have to be aware that each human being carries a legend within himself. Not necessarily the image that we project, but rather a legend with which we flirt and have a romantic experience with. And it's deeply secret and hidden, and we have to get it out. The tragedy of late life is that the legend begins to run out. You cannot romanticize anymore with yourself. And therefore, one needs to be dependent upon previous life experiences and memories of when one was master of the situation, and to get that out of the individual in order to do a good therapeutic job.
This concludes another edition of Psychiatric Recorder, a continuing education service from SmithKline French Laboratories. The views you have just heard are, of course, those of the individual panelists. Now, here's a brief message from SK&F.